just waiting some. Okay. All right. I think we can start, and we start in pathology. So, good evening, all, by the way. I start in pathology. Last time we discussed the renal cell carcinoma, the renal bladder cancer, acute pancreatitis, both cancer, esophagus and stomach, ulcer, especially peptic ulcer, and also venous ulcer. And lastly, also we examine the patient with acute appendicitis have valve disease, so we afraid from infective endocarditis. And at the end, we have the skin tumor. All right. So today we start by thyroid tumor. Again, pathology is important to know the culture in UK. So they ask you about the cancer or common disease in United Kingdom, not in your country. So they don't ask you about dengue or malaria or any of this disease. So the common cancer or common disease in UK is usually cancer colon, cancer lung, cancer breast, inflammatory bowel disease, acute pancreatitis, and of course, diseases related to high alcohol like acute pancreatitis and gastritis. Okay, so we start by thyroid cancer. So usually you have a script like this. So 25 years old woman, of course, even pathology, you have exam scenario, and this is outside in the room outside. 25 years old woman complain of goiter after performing right hemothyroidectomy. Histopathology of the excised mass proved to be papillary thyroid carcinoma. It is important to know that papillary thyroid carcinoma usually occur in young age and age of 20. And after that, the examiner asks you some question. Okay. Anyone ready? We just ask him. Okay. Anyone? Don't be shy. Okay.
السلام عليكم ازيك دكتور
Alaikum
شيرين.
salam, you can start. So you see the scenario now. So this patient is young, 25, and we excised hemothyroidectomy, we remove the right lobe and the isthmus as safety margin, and it is papillary thyroid carcinoma. Okay, so our next
Okay.
question is, what is the next step? You already know that they have a cancer, and it is papillary thyroid carcinoma. So what is the next step? What you do for her later, or next step?
Okay, could you bring the stem back again?
All right. Yes.
I'm going to run some investigations like BIT-CT in case of METs.
They have no mets. Usually, you can write CT, thorax, abdomen, pelvis, no metastasis. Usually, papillary thyroid carcinoma is spread to lymphatic. And you already, if you write right hemothyroidectomy, if you have lymph node, usually you remove it. I just ask you simple question. What is the difference between papillary thyroid carcinoma and the other thyroid carcinoma? Apart from it is
Okay,
occur in young age, what is the difference?
papillary thyroid carcinoma metastasis to lymphatics,
Yes,
while follicular thyroid carcinoma metastasis to the blood.
yes. Okay, but
Um,
in the nature of the tumor, what is also the difference? For example, it is occur in young age and multifocal. Okay, so suppose this patient is follicular thyroid carcinoma, hemothyroidectomy is enough, followed by radioactive iodine. But in the papillary thyroid carcinoma, it's better to have completion thyroidectomy, so you need to remove the normal part or the normal left part. We don't have much debate about it, but you can find in some books they mention that we can, if they have a safety margin of the tumor less than 1 centimeter, safety margin more than 2 centimeters, you can follow up the patient. But the classic and the basic and the gold standard for papillary thyroid carcinoma is to do completion thyroidectomy or removal the other part of thyroidectomy of the thyroid, followed by radioactive iodine. Okay.
okay.
So what other thyroid tumor you know? You mentioned follicular spread by blood. What else?
medullary thyroid carcinoma, Hertel cell thyroid carcinoma,
No, Herschel cell is a very rare and it is a variation of the follicular. So it's still under follicular but bad prognosis. So we have papillary, we have follicular, we have anaplast and medullary. Okay, so what is the origin of medullary thyroid carcinoma?
medullary thyroid carcinoma, parafollicular C cells.
Parafollicular C cell. So what is multiple endocrine neoplasm type 2? Type 1.
Type 1, okay.
Yes.
It's a group of neuroendocrine tumors originating from neuroendocrine originating. It's a type of endocrine tumors originating from endocrine system, usually hyperplasia and neoplasia
Usually
of
they started by
pituitary.
B. B. So it
Okay,
is,
okay. I'm going to
yeah.
mention this:
Yeah. Okay.
pituitary adenoma, parathyroid
Okay.
hyperplasia, and uh, and pancreatic tumors like in serenoma, for example. Pancreatic adenoma or tumors in general,
I
like in
forget it is
serenoma.
pancreatic or not. I forget it, by the way.
لا
Okay.
pancreatic.
All right. So what is multiple endocrine neoplasm type 2?
Medullary thyroid carcinoma, almost in 100% of cases, and parathyroid hyperplasia, and pheochromocytoma, tumor
What
of
is the
medullary
tumor marker of the medullary thyroid carcinoma?
calcitonin.
So what is the origin of pheochromocytoma?
It's the medulla of adrenal gland.
And what is the tumor marker?
Pheochromocytoma, okay, in blood, free methanephrin, and in urine, vanillmandelic acid and free methanephrin also,
Okay.
and that's enough.
And what?
That's enough.
That's enough.
Free
Okay. All
methanephrin in
right.
blood.
So what other tumor marker you can find in urine? You mentioned phenylmandelic acid or VMA in the
Free
pheochromocytoma.
methanephrin.
What else?
Free methanephrines and fractioned methanephrines.
No, no, we speak in general. We don't speak about pheochromocytoma now. We speak about pathology in the urine. What is the tumor marker you can find in urine?
Okay, for plasmacytoma, we can find Benz-Johnson protein.
You mean for multiple myeloma, you can find Benson-Johnson protein.
Oh, okay.
Okay.
Oh,
This is the second. What is the third? Only three. What is the third? Is the tumor arise from appendix?
carcinoid tumor, we can find hydroxyindole acetic acid in urine too.
Yes, so we have three tumor marker in the urine. In the carcinoid tumor, which is occur, it is rare but can occur in the tip of appendix, and it is the serotonin, and the product of serotonin in urine is 5 hydroxyindole acetic acid, or 5-HIAA, or 5 higher. The second is multiple myeloma, and you have Benson-Johnson protein in the urine. The third, which is we speak about it now, is the pheochromocytoma, and you can find phenylmandelic acid or VMA in the urine. So usually in the exam in pathology, we have difficult questions. This is one of the difficult questions. What is the oncogene of multiple endocrine neoplasm type 2?
RET oncogene found in chromosome 11.
Okay, all right. Can lymphoma occur in
And
thyroid?
yes, I think a lymphoma can occur in thyroid.
After which disease?
After infection with H. pylori, it can cause
No, 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 no. It is very H. pylori can cause lymphoma in the
maltome.
intestine, but this is after Hashimoto. Okay, so
Okay.
we just review. I back to you again. So tumor of thyroid can be benign like adenoma, can be malignant like papillary, occur in young age, spread by lymphatic, follicular spread by blood, anaplastic spread locally, medullary, and medullary can be run in family if this is part of multiple endocrine neoplasm. This is a percentage. Although thyroid tumor is rare, but the commonest is papillary. And the difference of papillary in other, it is multifocal and can occur in young age. So this is why it is important in papillary, we make total thyroidectomy. In the other cancer, if it is localized to one lobe, so we have hemispheroidectomy, including that we remove the tumor, we remove the lobe, suppose it is right or left, and the isthmus as safety margin. But in papillary, till now, we prefer to remove the whole thyroid gland. So again, papillary is 20 and the multifocal, the other is not multifocal. Multiple endocrine neoplasm, medullary thyroid carcinoma can be part of multiple endocrine or MEN2 syndrome, which can run in family. So we found the patient say, many of my family have a cancer thyroid, so it is most probably it is medullary and it is related with pheochromocytoma. The other goiter, it is due to lack of iodine, so it's different issue. This is multiple one, so we have pancreatic, we have parathyroid, we have pituitary, all are adenoma, so it is not important because it's benign lesion. Multiple endocrine neoplasm type 2, medullary thyroid carcinoma, pheochromocytoma from adrenal medulla, parathyroid adenoma, can be associating in some cases with neuroma, can be with marfanoid picture. The oncogene, as you mentioned, it is RAT proto-oncogene. It is in chromosome 10q. Q means a long arm, by the way, and the number is the sequence of amino acids. It is not important. We don't ask about this. All right. So we mentioned this is Hashimoto, and this Hashimoto can be followed by non-Hodgkin lymphoma. So back to you again, doctor. So what is Hashimoto?
Hashimoto.
Just in simple way.
It's an inflammatory disease occurs to thyroid gland.
So it is autoimmune inflammatory disease. So what is the value of ultrasound in thyroid swelling?
To determine the nature of the swelling, if it's cystic or solid.
So what is if
This
it is cystic? What you will do? What is the next step?
I'll do FINAC, fine needle aspiration cytology.
What does cytology mean?
Cytology, study of cellular structure study of cellular structure and function, and the tissue and the sample will be devoid of any background architecture.
So what it means? It means that you can diagnose by cytology carcinoma in situ or not.
We can of course we can diagnose carcinoma in situ, but we can't differentiate between.
No, it is impossible to diagnose carcinoma in situ because carcinoma in situ you need to see
Okay.
the basement membrane, and in fine needle aspirated cytology you only examine the cell and see it is malignant or non-malignant. But if you need to know it is carcinoma in situ, you need to see the basement membrane. So we don't have basement membrane. So in this situation, you need to have surgery or to look at biopsy. All right. Of course, one of the
Okay.
complications of thyroidectomy is injury of the external laryngeal nerve, or especially the this is branch from the superior laryngeal nerve. So if this
Okay.
happened, what is the effect of that?
Paralysis of the cricothyroid muscle, which lead
Okay.
to a loss of a high-pitched voice, inability to change tone or voice tone. Of course,
Okay.
this will be bad for a singer, for
All
example.
right. Okay. So the loss of high-pitched voice because the affection of cricothyroid muscles. It's supplied by the external branch of the superior laryngeal nerve, or we sometimes call it external laryngeal nerve. And it is injured anatomically when you ligate which part of the thyroid?
Superior thyroid artery.
Superior thyroid artery. Okay. All right. So what is the cause of sudden increase in thyroid cyst?
Hemorrhage,
Okay.
hemorrhage infarction,
All right. Or
malignant changes.
all right. What is Graves' disease? You hear me? Graves. What is Graves'
Okay.
disease? Yes. It is thyrotoxicosis. It is just a primary thyrotoxicosis. Okay. Dr. Muhammad, in exam, I think you don't enter the exam before.
No,
Yes. So in
this is
exam,
the first time.
they ask you about 15 questions in 9 minutes.
Mm.
Okay, so usually your answer is just simple answer. Okay, if you don't have simple answer, you don't reach number 16. You got the idea? So it is just
Okay.
simple word like what is Hashimoto is autoimmune inflammation of the thyroid gland. All right, we show you the picture, and this is histopathology picture, and this is macrocalcification called Sumoma body, and it is in the thyroid gland. So what is the disease in this patient? This is look like empty nucleus. If I enlarge this, they look like empty, but actually the nucleus in the periphery. And this cell, we called it in some country orphan Annie cell. So it is diagnosis of what disease? Thyroid.
Papillary thyroid. Papillary
Papillary thyroid
thyroid.
carcinoma. Yes.
Mhm.
And of course, the mama body is macrocalcification. So it is the same. All right. Okay. So as you see, it is simple question. You have many questions, and all these questions you need to finish or you answer it in just one sentence. All right. So you don't have a time to speak more because he ask you many questions. At least 16, sometimes 20 in 9 minutes. All right. Well done, Dr. Muhammad. Okay. After that, we have diverticulum. So it is just general. After that, of course, we go to the colonic diverticulum. Does anyone need to try again? Don't be shy.
I'd like to try, Professor.
Okay, Dr. Omar, you are welcome. Okay, so what diverticulum, Dr.
Thank you, sir.
Omar? In general.
Diverticulum is a pouch or outpouching of a hollow organ.
Okay, can you classify it in the classic way like congenital and acquired?
There is congenital diverticula, such as the Meckel's diverticulum. There is the
Okay, in
acquired
this
diverticulum,
Meckel
which can be.
diverticulum, what it contains, sometimes have a bleeding, sometimes it be mimic appendix. So why is sometimes have a bleeding, although it is rare?
It can contain ectopic gastric mucosa.
Ectopic gas. Of course, it is occidental discover and even gastric mucosa is accidental discover. So you have congenital like Meckel diverticulum. This Meckel diverticulum is true or false diverticulum?
It's a true diverticulum consisting of all the walls of the
Okay,
gastrointestinal
I
tract.
think I show you the picture. So this Meckel diverticulum is the whole thickness, so it is true diverticulum. What other diverticulum you know acquired?
There are acquired diverticula. These can be classified into pulsion and traction diverticula.
Okay.
Traction diverticula can occur in the esophagus, for example, due to tuberculosis of mediastinal lymph nodes and traction on the
Okay, this is rare. What
serosa.
is common? What is common?
The pulsion diverticulum, which is characteristic of diverticular disease of the left colon.
What else? What about this pharyngeal pouch? What is pharyngeal pouch?
It's called Zenker's diverticulum. It's due to a loss of relaxation of the cricopharyngeus muscle.
What is cricopharyngeal muscle? It's part of which muscle?
The inferior pharyngeal constrictor.
Inferior constrictors. Okay, so it is in between and they have this pharyngeal pouch. What is dangerous of this pharyngeal pouch?
Aspiration and recurrent chest infections.
Okay, no, can be
And
iatrogenic, something
perfor-
serious.
yes, perforation during upper GI endoscopies.
Yeah, so can be perforated during OGD. So usually in England, in the people over 70, they have this barium swallow just to confirm that it is not pharyngeal pouch because if you have pharyngeal pouch, it can easy to perforate it. If perforated, it can cause mediastinitis and it is fatal. Okay.
Yes.
After that, we speak about what is the common diverticulum in general surgery is colonic one. Okay. So what is colonic diverticulum?
These are multiple outpouchings of the sigmoid colon
It is true or
or the left
false?
colon. It's false diverticulum, a false pulsion diverticulum,
What you mean by false
due to
diverticulum?
it only consists of the serosa and the submucosa.
Okay, so it's not all layer. So it is just a false diverticulum. Okay, so what presentation of patient with colonic diverticulum?
I'm sorry, of the mucosa only, not the submucosa.
Yeah,
The mucosa.
mucosa only. And the common which
Yes,
part of colon?
in the sigmoid colon.
Sigmoid colon. If this is inflamed, have diverticulitis, what is the complication of diverticulitis?
It can cause stricture, it can cause bleeding, it can cause perforation and peridiverticular abscess,
If you have
or it can
perforation, if you
cause
have perforation, how to manage? After resuscitation and all this, what's the operation you did for perforated diverticulum?
a Hartmann procedure.
Hartmann procedure. So you remove the area and make Hartmann procedure, which is bring the two end outside nowadays. If the patient have tiny perforation and perinephric, not perinephric, paracolic abscess, so how to manage? Localize the abscess, not generalized peritonitis. How to manage?
Yes, image guided percutaneous drainage.
What you mean by image?
Either ultrasound or CT, usually ultrasound.
Usually ultrasound, we don't see CT have a precaution and the X-ray. So usually ultrasound guided, we put something called the pigtail. Okay,
Yes.
so this is the diverticulum as you see, and this is the picture from the colonoscope. Of course, we don't advise to do colonoscope except once for diagnosis because in the colonoscope we inject air, so can be easy perforate the diverticulum. This is a perforation. If you have perforation here in sigmoid colon due to diverticulum, how to manage? You just close the
In the sig-
perforation or remove the area.
no, we do a sigmoidectomy and then we bring out the two ends of the bowel,
All
one in
right.
a mucus fistulae and the other in a colostomy.
Okay, so even if you have tiny hole like this, don't suture because this is under
Yes.
pressure, the bad healing. So we need to make the remove part of the sigmoid, and we made Hartmann procedures. Later we can make primary anastomosis. Usually it is difficult to do primary anastomosis in diverticulitis. In cancer colon you can do, but in diverticulitis usually the tissue is inflamed. Okay. And of course, it can cause fecal peritonitis, which is 70% mortality rate. Okay. So, Dr. Omar, we change the topics now. It is important to know because we ask you an exam about 20 questions. So sometimes we start by topic and in the middle another topic and at the end another topic. So maybe start by cancer esophagus, for example, followed by cancer stomach, followed by peptic ulcer. So usually it is not related. So for example here, and it is common in exam after diverticulitis, I ask you about endometriosis. Different topic because we don't have much question in diverticulitis. Of course, diverticulitis is not precancerous condition. What is endometriosis, Dr. Omar?
It's the presence of endometrial tissue and glands outside the uterus.
All right, like what? What is the area confounded?
The ovary, the pelvic cavity, sometimes in the lungs, it's been
Okay.
recorded, in the
Sometimes
umbilicus.
even in umbilicus. So what happened, of course, if it is born by this, but at time of menstruation, when the patient become adult, what happened to her?
There's if there's intrapelvic collections of the endometrial tissue, then pelvic pain with the cycle,
Pelvic
intense
pain,
pelvic
or
pain,
if suppose it is in umbilicus, what's the patient presented by?
pain and swelling in the umbilicus, which coincides with
And
the
and
menstrual
also
cycle.
bleeding at time of menstruation.
Yes.
Okay, they can bleed it. Of course, this is can cause fibrosis, can cause adhesion, can cause cyclic pain at time of menstruation. They a lot of disease. Of course, we don't speak much about endometriosis because it's related to general surgery, but it is just one or two questions about the site, and also it is kind of the differential diagnosis of the vague abdominal pain. Okay, thank you, Dr. Omar. So, any
Thank you, Prof.
question till now? After that, we have a common topic, so which is important in exam, which is CE colon or cancer colon. So, in exams, you must have question or topics about cancer colon, acute pancreatitis, peptic ulcer, because this is important physiology, pathophysiology or pathological topics. So here we have 65 years man attend outpatient clinic complain of irritable bowel habit. Irritable bowel habit mean constipation and diarrhea. So what other question you will ask to sort out cancer colon? So, before you enter, we speak about cancer colon or precancerous condition or familial adenomatous polyposis. So, this is all topic we will discuss in these stations. Anyone ready? Don't be shy. We can help you. Don't worry. Anyone?
Professor, I'm ready if no one else wants to volunteer.
All right. Okay. So, what is the presentation of patient with a cancer colon?
You're speaking to me, Professor?
Yes, yes. I will start with you. What is the
Okay, so
presentation of patient with
I'll
cancer colon?
altered bowel habits, which is already mentioned, loss of weight, loss of appetite, general malaise and fatigue,
No, no,
maybe intermittent
still about colonic symptoms. So colonic symptoms, they have altered bowel habit. What else can be presented?
bleeding per rectum if it's a
Bleeding per
distal
rectum and
tumor.
usually painless or painful.
Painless, it's painless.
Painless. So painless bleeding per rectum can be fresh blood, can be digested blood according to the level of the cancer. And also something called tenesmus. What is tenesmus?
It's the urge to evacuate the bowels
No,
without
urge is
subsequent
urge. Like
evacuation,
tenesmus is incomplete evacuation.
incomplete
Okay.
evacuation.
How to differentiate
Okay.
between diverticulitis and the cancer colon from the history?
Cancer colon would usually be more protracted in history, and without pain, it's painless. Diverticulitis automatically means the patient is in pain. The site is usually left iliac fossa if it's
No,
diverticulitis.
both are left, by the way. Both can be left. The
No,
common cancer is
I'm
rectosigmoid. No, I think I don't know what happened, but it's okay. So I think is what happened is you can see here now. In diverticulitis, we have a fever. In cancer, we don't have a fever. Okay? So we have the colonic presentation or cancer colon, irritable bowel habit, mean constipation, diarrhea, bilious bleeding per rectum, fresh or mixed with stools, tenesmus, incomplete evacuation, fecal incontinence, loss of weight, loss of appetite. In the diverticulitis, not in the diverticulosis, even diverticulitis, have a fever, tender left iliac fossa, leukocytosis. Of course, diverticulosis can cause massive bleeding also. It is the same. Okay, so how to classify the colon tumor?
This can be either benign or malignant.
All right, so it is important when you classify thyroid tumor or colonic tumor. If I don't ask you, can you classify the cancer? So you start by benign tumor like adenomas and cancer. Okay, so we have benign tumor like what?
Benign tumors include adenomatous polyps,
What type of adenomas,
inflammatory polyps.
what type of adenomas,
There's the villus tubular and tubulovillus adenoma.
Okay. All right. And we have familial adenomatous polyposis. What is familial adenomatous polyposis?
It is an autosomal dominant disorder characterized by the presence of hundreds of adenomas or adenomatous polyps in the large bowel.
Okay, so it is precancerous or risk of cancer.
It's associated with 100% cancer risk by the age of 40.
All right, okay. So we have another hamartomas called Betz-Jeher syndrome. It is the small intestine and the large intestine polyp. Is this can turn malignant or never?
No, it's a hematomatous polyp. It's not pre-malignant.
All right. Okay. So again, we have benign tumor of the colon. Adenomatous can be villus, can be tubovillus. We have familial adenomatous polyposis, which is precancerous condition, can cause cancer at age of 40. So in UK, usually at age of 30, they have subtotal with ileorectal anastomosis, and we have juvenile polyp also. After that, we have a cancer. One of the polyp which is worried nowadays is called serrated polyp. So serrated polyp is precancerous and is dangerous, by the way. All right, so we have a polyp like this and removed by snaring, and we have multiple polyp. These polyps usually can adenomatous, can be BCGR like hamartoma, can turn malignant. Very rare we have inflammatory, but it is pseudopolyp like an ulcerative colitis. Okay, so this pseudopolyp of the ulcerative colitis is not true polyp. Ulcerative colitis, of course, a pre-malignant condition. So, Dr. Omar, so how to classify after that the polyp according to macroscopic and the macroscopic started by macroscopic gross anatomy? What is the shape of cancer colon?
Macroscopically, it can either be fungating, ulcerating, or stenosing lesion,
No,
or a
just
stricture.
one by one. So fungated, it just means that it is a
Yes,
polyp
it's a
and can
mass.
be a
Yes,
mass or can be ulcer or can be what?
a stenotic lesion
A
or a
stenotic
stricture.
lesion. So, like any cancer, like cancer esophagus, we can have a mass, we can have a stenosis, we can have ulcer or malignant ulcer. And under microscope, what is the common variation of the cancer colon? It is
Adenocarcinoma.
adenocarcinoma. So, as you see here, so we have polyp, ulcer, stenotic, all are adenocarcinoma. Of course, the diagnosis by taking a history, colonoscope, and take biopsy, and you have a tumor marker which is carcinogenic embryonic antigen, and in screening program in many countries we have fecal occult blood. Okay. Of course, what is the common site of the cancer colon?
The sigmoid.
Rectosigmoid. Rectosigmoid, the common 65% is rectosigmoid. Why cancer cecum? Cancer cecum is difficult to diagnose.
Because the cecum is spacious and roomy, and by the time we diagnose, the patient is usually in an advanced stage.
So
They
what
don't
usually
usually
is the
present with
patient
intestinal
presented by?
symptoms of iron deficiency, anemia such as fatigue, shortness of breath with effort.
Okay, so the usually cancer in the cecum is presented late and usually presented by anemia. So if you have patient with anemia, unexplained anemia, so can be cancer cecum, so colonoscope must be done. Is not give constipation, not give bleeding because the blood will be digested. So this sigmoid, this cecum, cancer cecum, which is difficult to diagnose. So this is why it is presentation is late. Can be ulcer, like this rectal ulcer or something like that. So how to know the patient have no metastasis?
Can you please repeat the
How,
question,
how,
if
how to
possible?
know if the patient have metastasis or not?
Clinically, I'll ask
Not
about
clinically, we don't
system.
depend clinically investigation.
Okay, so radiologically, I'd request CT, chest, abdomen, and pelvis
Yes,
with
so
contrast.
CT, thorax or chest, abdomen, and the pelvis, or we called it in some countries CAT, TAP, TAP. All right, so it is very important just to exclude. What is the common site of spread of cancer colon?
The liver is the most common
Why?
because it's the metastases are carried to the liver via the portal circulation.
Portal circulation, because the venous drainage of the colon, for example, through inferior mesenteric and go to through the portal veins. Okay. All right. So how to stage the cancers? We have two staging, like Dukes and TNM staging. What is
Tenant
Dukes?
stage.
What is Dukes staging?
Dukes has four stages. There is the A stage, which is confined to the wall of the bowel. There is B, which entails that the tumor extends beyond the wall of the bowel. And C, there is involvement of the lymph nodes. D, there is distant metastasis.
Okay. So in TNM staging, if this is muscularis propria here and this is superficial to it is T1. So if the tumor invading nearby organ like uterus or renal bladder, we consider is T what?
T4.
T4. Okay, so we have TNM staging. So T4 invading the other structure, T2 invading muscularis propria, T3 penetrated muscularis propria. Of course, N0 no lymph node, N1 3 lymph node, N2 more than 3 lymph node 4, M0 no metastasis, M1 metastasis. Why it is important to know this TNM staging.
Because
For
according to the staging, will commence the treatment.
No,
Uh,
actually, we know the staging after remove the colon. So it is just to know the prognosis. The treatment is not difference. So if the patient in early state, it is good prognosis. Like if Dukes, for example, Dukes A, it is good prognosis, 90% 5-year survival. If have liver metastasis, is bad prognosis, maybe 15%. So it is important. Usually we know the staging or the level of spread of the tumor after surgery, especially TNM staging, because you can remove the lymph node and found at the end it is not infiltrated by the tumor. So it is can give an idea about the 5-year survival and the diagnosis. As we mentioned before, the follow-up the patient by CT, thorax, abdomen, and after that, after we remove the or did the operation, we follow up the patient by CT, by tumor marker, which is CAA, and if the patient have any presentation, we can do colonoscope. Of course, the follow-up after treatment, after surgery, after chemotherapy is done after 6 months, and then each 1 year. Okay, and this is the staging. So this is stage 4 or T4. Okay, I think these other topics. All right. So thank you, Dr. Omar. We hope
Professor,
another
I
one
just have a
help.
question.
Yes.
Isn't the TNM staging both clinical and pathological?
Yes,
So
it
what I
is
mean is,
clinical and pathological because if you operated in the patient and you send the lymph node, we don't know it is involved or not. So it is
yeah. So
done.
I mean,
It is done, but after surgery, not before surgery. Except the CT
how
can
about
do it.
before?
About what?
How about before? I mean, before the surgery, if I determine that the
No, before
patient
the
has
surgery, they
metastasis.
give you idea about if the patient have metastasis or not. And if patient have metastasis, so it is advanced case. So staging here is have no value because you know that it is bad prognosis. But if the patient in
Okay.
the early stage and no liver metastasis, so we know the staging after surgery. So it is clinical and pathological and radiological.